Hello and welcome to the Brand Ramaco podcast. I have with me today Eric Fisher for the third time. Hello and welcome. Thank you for coming back.
You're very welcome, Brandon. Thank you for having me back.
So, Eric is the author of The Martial Art of Recovery Self Mastery Practices to Subdue Addiction and Achieve Mental Wellness. He's a Canadian certified counselor with 13 years of experience, and we've had two great previous meetings where we talked about just an introduction to counseling at our first meeting. Then we talked about specifically anxiety, treating addiction, some of the techniques, and we even talked a little bit about patient-client or doctor-patient confidentiality and how that sort of works. And today I always have more questions and more I want to share with the audience. So thank you again. So my first question, where I'm going to steer the conversation, is the explosion of health and wellness coaches. Because it's an unlicensed profession to be a health coach or a wellness coach. Even nutritionist is unlicensed in almost all places. And in the States, there are certifications, but no government is forcing a certification to call yourself a wellness professional. In the States, it's actually, I think it might be international. They're certified health and wellness coaches, and they have to have so many hours of monitored experience and things like that. But aside from that, it's the Wild West. I know someone who did a 10-hour course, and she got a certificate, and she's certified by this company that put their course on Udemy. So she paid $10 for a 10-hour course, and she's a certified life coach by this company. So what are your thoughts about life coaching? Because often they claim some of these Udemy courses are on CBT and are claiming they're counseling for addiction, claiming they're counseling for basically life trouble, depression, and things like that. What are your thoughts?
Dr. Ramako, I would ask one question. Where is the regulation? Yes, where is the oversight? Where is the even the practicum experience? Where is the supervision when it comes? I guess that's more than one question. So where is the supervision when it comes to a health and wellness coach or a wellness coach? Because when I did my master's, there was supervision, there was the practicum experience, there was that accountability. And I'm not saying that every wellness coach out there is not accountable. However, for those that want to slip through the accountability web, it can be a lot easier. Like you said, $10 for a 10-hour course and I'm good to go. I mean, it really slaps. It feels like a slap in the face to everybody that's been through, like yourself, some very extensive training. And for me, that's been through bachelor's and master's and ongoing training. It just it just seems like a very quick turnaround, which I mean, hey, sounds very convenient and great. So that's the biggest piece for me. I mean, the British Columbia's counseling was recently included in the Health Professions Act up here, just like literally like a few days ago, which is great for them. And so they're getting regulated, and Alberta is lagging far behind on that. And we're supposed to be regulated, hopefully, I don't know, hopefully within the next year or two. So yeah, and that's going to make it to where up here counselors cannot practice unless they're under a certain college. I don't think there's a certain college for these wellness coaches.
That's
There's
right.
no accountability. There's no accountability. So that's my major concern.
It's mine too. I have a love-hate relationship with it though, because I think there is a benefit to the availability of them if they're just doing more the coaching, like really leaning into a coach and guiding people, trying to just get people's thoughts sorted, but then pointing them in directions that, wow, okay, you need to go see a real counselor to tackle that problem. We've realized that you have a real mental block there, an emotional block there. You're dealing with that. that's outside of my scope. That's a mental health professional scope. And now I have to refer you. If someone needs
Yes.
surgery, I'm not going to do, I can't, actually, I can do surgery in, so I'm a chiropractor, but chiropractors are actually, or can be trained and certified to do surgery in Oregon, where I was trained.
Mm.
Because in Oregon, we're primary care physicians. We can deliver babies and do minor surgery. Uh,
Wow, I did not know that for chiropractors in Oregon. Okay.
it's very different when people are like, "Oh, so you do crick cracks?" And I'm like, "No, I don't do crick cracks." But because I'm a diagnosis specialist, management specialist, imaging specialist, uh, there's and I was trained as a primary care physician. So the training and the licensure can be quite different. I think the way Oregon did that to keep the other chiropractors out of the state, because to come to
Oh,
get licensed in Oregon, they have to
oh.
write, even if they don't plan to, they have to write a minor surgery exam and an obstetrics exam, which none of them received any
Mm,
education for. So it's sort of
that's a,
smart from the government's point of view or from regulations point of view. Let's keep the other riffraff out of our state. Only Oregon trained chiropractors are in Oregon.
yes, very elitist is not the word. Just wanting to pigeonhole, wanting to keep just the organ
Well,
practitioners. Yeah.
it does
Yeah.
control the quality,
Yes. Yeah.
and we're trained not to crack, and the crack isn't the be all. It's actually very rehab focused. I think it's a little insufficient still. I think medical training is insufficient, but I thought it was insufficient to handle everything that's out there. That's why I got more training. But it is more broad in terms of skills and knowledge, I think, than some of the other schools. Some of the other schools have classes where they learn about the religion of chiropractic, this chiropractic philosophy, and they learn more history. And at our school, we replaced the history classes with um, journal club, reading journals and sharing journals. So it was a very different, or when I talked to other chiropractors, it was a little bit of a different experience. Chiropractors from Oregon are known as not being that good at crick cracking people.
Okay. Good to know. Good to know. I'll make sure if I need some quick cracking, not to go to Oregon.
Yeah, go to one of the other states.
Yeah.
But
Yeah.
that's actually all of that led into what we're talking about the licensure, and it's about referring out when you go
Yes.
past your scope of practice.
Yes. It's similar to like a sponsor in Alcoholics Anonymous where, I can give my experience and some suggestions, talk about the 12 steps of AA, yet it comes a certain point where, okay, I'm not a couples counselor, or I don't know that much about maybe wellness, health. I need to say, hey, maybe you need to go see a professional health and wellness coach. If they know their scope of practice, their limitations,
But
it's
who knows whether
just
that's covered in their course?
and who knows? Yeah, and it may not be, and it would be really sad and scary, and yeah, that would be really concerning if it wasn't. I mean, even for me, I have to know my scope of practice. I've
But
had
there's
people,
no
yeah,
criteria, so it's not necessarily in the course.
yeah, and that's not good. It's not good.
It is so anyway. I recommended it in my book, but with a big asterisk, being like you have to be careful. Same thing with the
Yes.
nutritionist. Nutrition's actually fairly simple if we're talking basic nutrition. I
Hmm.
think. Well, actually, I made the argument that since basic nutrition is fairly straightforward, macronutrients and micronutrients, that you can take a nutritionist certification course in 40 hours and it can be a good certification.
Hmm.
So if you
Yeah.
wanted to learn to get to see a nutritionist, you might actually want to balance the cost and be like, okay, why don't I just become a nutritionist?
Yeah. Yeah. I mean, if I've already done 40 hours, like why not go for the rest? Yeah.
So yeah, I think you can find a good nutritionist with only 40 hours of training. It's possible. Obviously, dietitians have thousands of hours of training and can really gear you specifically for cancer or something. Same thing with a life coach. I think a life coach, if you want to just speak to someone just to talk about your goals and maybe you have no knowledge, someone just to tell you about setting smart goals,
Yep.
specific, measurable. Um,
Yes.
So like that's good. I like, and the cost has come down for these online sessions because so many people are doing it. So availability is there. So there's a balance of I like more availability. It's possible they're doing a good job, but just cautious to everyone out there. You don't know what you're getting.
Yeah, yeah, it's really putting my hand in a bucket and see what comes out.
Hmm.
Yeah.
So last time we talked about your treatments for anxiety and addiction, and today, and I know this isn't your specialty. Not, and I know when you're treating mental health, you end up treating a little bit of everything because everything overlaps. So I've referred a lot of people for mental health help, sort of co-treatment for chronic pain. And I used to work in a drug rehab facility because as they were
Mm,
coming off of the drugs, a lot of them were addicted to opioids because of pain. They started and they got addicted and then ended up homeless on the streets and then end up in this facility and they still had the pain. So I was there treating the pain part.
mm.
And so I suspect that might tie in with addiction. So what are your thoughts on treatment for chronic pain? Do you have any thoughts about common treatment protocols that you like to use?
When it comes to chronic pain, I recently learned, well, it was a few months ago, I was listening to a podcast and it was a pain psychologist that was speaking. And she mentioned how, doctors think they're only treating the physical pain and psychologists and counselors only think they're treating the emotional pain. But actually, we're all treating both. Yeah. And that was a good eye opener for me and a good clarification because for the longest time I thought, oh, it's just the emotional pain. And I can't remember her name off the top of my head, but she did write back in COVID time a chronic pain management workbook, and it's available on Amazon. And she mentioned it's been doing really well. And she talks about how important psychoeducation is for pain itself. So I think that would be a really good intervention is just for people to learn as much as they can about chronic pain, how it affects the body, what's happening in the body when it comes to chronic pain. I think all that's important. And I do believe that treating the emotional piece, of course, I'm biased because I'm a counselor, but treating the emotional part cannot be overstated, since often with trauma, the physical and the emotional with chronic pain are going to exist.
So I often quote or recall one study where they had doctors talk to chronic pain patients and actually spend the time, although with the insurance system that they can't really charge for this time. So they're de-incentivized to do this, but they actually spent like 20 minutes per patient explaining how the brain works, how the nerves work, how the pain sensors work, how the pain part of the brain works. And it decreased people's pain by 30% on average. On
That's amazing.
average, 30%.
That's amazing. That's a huge drop in percentage. 30% is huge.
It's
Yeah.
so I have obviously it's in my book. It's also on YouTube, although I don't own the video. But it's in my health education playlist, and it's me giving a talk about how pain works. If someone listening wants to hear that talk, I also put it on the podcast sources, an audio version of it, so it's out there. But again, that's explained the sort of the science behind it. Sometimes you have to go deeper into trauma and address that. And you have to be more comfortable with your body because pain comes from the emotion part of the brain.
It
Without the
is.
emotion part of the brain, there is no pain. Pain is an emotion. You can't
Yeah.
get around it. And that part of the brain has access to your memories and has
Hmm.
access to what you're thinking. And it does its own sort of calculation to decide whether to send pain to you. And so pain doesn't equal damage. There's not a good connection there. And I'll use the story I used actually in the talk. A lot of people think cookies equals happiness. Like a lot of people, pain equals damage and cookies equals happiness. And people are like, yeah, cookies equals happiness. That makes sense. Well, maybe there's a bit of a relationship between the two that they can sometimes one can lead to the other. But I'm sure there's depressed people with a box of cookies on the shelf,
Hmm.
and you could be
Yeah.
happy without cookies.
Yeah. Yes. That's also true. Yeah.
And pain is
Yeah.
very much like that. There's people with damage that don't feel any pain, and there's people that have lots of pain with no damage or nothing that's causing damage.
Yeah.
So it's been so some people are so scared the mind can recruit motion receptors to respond as pain. Well, I don't want you moving your shoulder. I'm going to, every time you move your shoulder, I'm going to make it hurt.
Hmm.
So
Yeah.
does
Yes.
that ring any bells with some certain patients?
Yes, yes, indeed. And, I think that that brings up the importance of movement when it comes to pain. And, like the brain's telling me, do not move that shoulder. I mean, you'll never get better. And I think just hearing an addiction doctor talk about that a few months ago, like, yeah, gotta move, gotta move.
Have you, no, there's a bajillion treatments. There's of course the mirror therapy, which is in particular for missing limbs.
Mm.
But there's another treatment. I forget the, of course, everyone puts a trademarked name on everything, every technique. But it's basically just using a hairbrush and brushing people's skin of where they have pain.
Mm. Oh, interesting. Yeah, I haven't heard of that one before either. Okay. So you brush the person's skin and it helps the pain.
I do this on patients where I touch their skin and they say, ouch. And I realize now it could be they have an infection or there are a couple conditions where it's so inflamed and there's it's basically can be chemical. It's possible that that could be causing the pain sensors to go off. Let's say if it's hot and swollen, then
Okay.
yeah, okay, that's reasonable. But if this is a chronic pain case and I touch their skin and they say ouch, I know that it's the brain. The brain is way oversensitive.
Mm.
So you have to train the brain that, hey, it's safe to touch the skin. Touching the skin doesn't cause any damage. And
Mm.
frankly, it's 100% success with I either use a brush or my fingertips, um, or even just I start with just fingertip pressure, and then I sort of distract them by talking. But as I'm talking, I'm just getting more pressure until I'm holding their arm quite firmly, and then I call attention. So you've probably noticed by now I'm holding onto your arm pretty firmly. I'm like, yeah, I noticed. Like, why are you doing that? Well, does it hurt? No, it doesn't hurt.
Wow. And they're totally surprised.
Yeah,
Yeah.
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 Um, Vibration therapy is another one like that, where you just sort of overload the system with mechanical stimulation, which is non-offensive,
Mm. Okay.
and that can sort of tone down their system. They call
Mm.
it, I think, gate control theory because there's so much information go through that they cut off response from any of the pain signaling. But of course, that's more at the spinal cord level. At the brain level, that also helps just build confidence. Oh, okay, I have all this mechanical stimulation. This is a safe environment.
Hmm. Okay. Yeah. So it just helps the brain recognize I'm in a safe place, like gate control theory. Okay.
Yeah, so they're experiencing
Yeah.
mechanical stimulation in a scenario that's safe. Whereas
Yes.
before, everything they experience was a potential. Okay, that could have hurt me. Ouch.
Mm. It reminds me of accelerated resolution therapy because in that, which I've talked about on here before, there's a script for pain management, and I guess it'd be similar to gate control theory, like where I'm actually safe in this environment with what I'm experiencing because what it does is, so we find all the different images that constitute pain for this person. I'd give you a case study. I did this
Mm.
with a lady. I think she had at least 7 or 8 images. And I will ask at the end if there's any more that are coming up after we work on those particular ones. And yes, she had more come up. And so we do some bilateral stimulation to desensitize, and we actually start to erase and replace those images. And then it's not the interpretation, the actual safety comes in. It was a really interesting experience. It sounds similar, but more of a, like, I guess it'd be more of a like a counseling therapy approach with ART.
Now, and again, I know I might be asking questions that you don't necessarily, because I know pain isn't your specialty, but do you do any that involve a lot of feedback, visual feedback, physical feedback. Sometimes they're with electrodes. Sometimes it's thinking of picture, visualizing the body. Um,
Like neurofeedback or
yeah,
biofeedback. I don't do anything like that, but I would love to because I've seen, just hearing about the research for biofeedback, especially for pain and even depression. Yeah, um, it shows somebody something that they didn't see before biologically and neurologically. So,
so one of the techniques that we talked about before that helps with relaxation, I'm sorry I forget the names of all these things. It's the one where you sort of contract your muscles and the strong contraction, and then relax, contract, relax. What
progressive uh,
progressive?
muscle relaxation. Yeah.
Um, that is actually I run through patients sometimes something similar um, for the muscles of the body for but with the visualization sometimes with the visualization. In fact, there was a study where they were treating patients just normally and treated patients with the anatomy pictures in front of them. And in fact, when they were on their back, they had the picture of the all the anatomy on the ceiling for them to see.
Oh, okay.
So
Okay.
now I'm working on this muscle so they could see that muscle. Now I'm going to have you contract that muscle and you're going to pull your arm forward. Okay, so that's the muscle that's working. But
Ah,
visualization like that, but that's a little awkward sometimes. But I do use the visualization. I do try so they know what muscle is being pulled. And then I imagine them imagine it strong, filling with blood, like all of this sort of strength
mm, I love that.
visualization.
Yeah, it's a guided visualization. Is control a part of that? Like, do you feel like control is a part of that experience for them, where
Yes,
they have more?
so many people feel
Yeah,
out of control
yeah,
with their body. They don't feel they're not in touch
mm,
with it. It's something
mhm.
that they're terrified of.
Yeah. It's like separate and apart from me. Yeah,
Yeah,
there's fear there.
yeah. Um, so I love this conversation. I love having you on. Thank you again.
Hey, I'm learning a lot today. Like yeah, I appreciate it. Thank you.
Um, so maybe I'll jump to depression because so many people who get with chronic pain also get depressed, and depression is it's an epidemic. Now the statistics sometimes confuse me because it's like 90 something percent of people will be diagnosed with depression at least once in their life or something like that. So it's
Yeah.
almost 100% of people are going to get depression. But if it's almost 100%, then isn't that normal?
Exactly right. Like how pathological is depression then with that prevalence rate? Doesn't sound like it's very abnormal or strange or pathological.
So either
From
we're
what I get.
diagnosing normal as abnormal, or there's something wrong with society that just everyone is getting depressed,
Yeah,
or it's
yeah.
both.
Well,
It's
yeah,
some combination of the two.
could be a combination. Yeah. Yeah, depression's it's a tricky thing. I remember talking with a psychologist back when I lived in Mississippi, and he mentioned something called happy depression. And the thing was, when people are coming out of depression, that's often a dangerous place to be, because then they have the actual energy to maybe do something to themselves.
Oh
Um,
yeah,
whereas, if they have, often with depression, there's that lack of energy, or there's the anhedonia, that pleasure deafness, or, difficulty sleeping or oversleeping or whatever it is, and they don't have the energy to do something. So I thought that was really a good thing to know. But yeah, yeah, anyway.
yeah. I'm thinking. I read a lot about medications and pharmacology. So for it's a lot of the drugs, there's a high likelihood, or high likelihood, there's a risk, if you're talking about the severe adverse events, there's a risk of suicide. It's normally very early on in switching to a drug, or it's as soon
Yeah.
as you come off.
Yes. Yes, the withdrawal or switching can be
Yeah,
really disastrous, like Prozac or whatever it is. Yeah.
yeah. Because it can cause a little roller coaster when you go on them, and it can cause a roller coaster when you come off.
Yes. Yes,
And that
indeed.
manic energy combined with the depression. Um,
Yeah, yeah, because that would be another way to look at happy depression is, yeah, the mania, the flight of ideas, and the I don't really need this sleep as much. It's not that I can't sleep or I don't want to sleep, it's that I don't need it, that mania. So yeah, it's a dangerous place to be.
So so someone comes with you and they say, okay, I don't have energy. I'm not hanging out with my friends anymore. I can't get out of bed. I don't think I can go to work anymore. Like I'm on the verge of not having the energy to go to work. Um, I need help. Like what's a treatment plan look like? What are some techniques you like?
I think a big piece is the ability to tolerate ambiguity. And I think we can do this with anxiety too, but with depression, a lot of times people are going to the worst possible scenario when something is ambiguous. And so trying to do some different homework techniques are just like, hey, could you just look at the possibility of neutral and or positive,
So to explore all their
possibility?
negative thoughts or their hopelessness thoughts and sort of
Yeah.
address them one by one.
Yeah, and that could be seek cognitive behavioral therapy, since you asked like what modalities or what
Yeah.
treatment approaches. So yeah, there's CBT, there's ACT, acceptance and commitment therapy. So that's incorporating like cognitive diffusion. So that's where I learn, and this is not easy by any means. This takes time, but I'm not a passenger, nor am I the captain of my thoughts. I'm observing my thoughts. I'm pulling back, I'm observing. So that's just one part. Psychological flexibility is another part with ACT. And then, yeah, there's accelerated resolution therapy for depression that I can do as well. And that brings in what's called the little liar in this therapy, the little liar that, yes, tells us all those things that are bad about us. We're worthless. I can't accomplish this. I won't ever get through this. And so we actually confront that little liar and start to reframe that at a very deep level. And obviously, there's just taking it one step at a time and really working on self compassion with depression. Another piece with depression that a lot of people don't realize is a lot of angry outbursts will happen with
Mm.
depression. It's not something that's talked about, but it is in the research, and it's something that can be specific to depression. And it's really working on anger management then. Um,
One aspect I just thought of, I've gone through bouts of depression. Well, of course, everyone does goes through depression based on
yes,
statistics.
yes.
And you don't have, I wasn't going to spend the money on a counselor. I was more just researching ways to kill myself.
Okay, okay, fair enough.
Um, because yeah, you don't want to leave the house, and I don't want to spend the money to see a counselor. And almost every single time, I think I went to three counselors for depression. Only one of them I would say really helped me.
Hmm.
And yeah, I needed someone's help to bring me to counseling,
Yeah,
or I wouldn't have gone. Help bring me and pay for me.
totally. Yeah, the motivation is not there, right? It's
um,
depleted.
yeah, do you have issues with patients that you need to see, want to see, and they just can't get to you?
Yeah, and I see that in addiction a lot because
Mm.
if they're active in addiction, then they're going to have a really hard time maintaining those appointments. I mean, that's one of the warning signs of leading even to relapse is I start to discontinue or avoid treatment, you know, opportunities.
I know they don't do this anymore. And but again, it's not my field. Maybe they do. But when I was young, there were, for example, my grandfather. He went through. I think he had a panic attack, and he was an inpatient. We actually had a mental health hospital close to our house. And I think Ethan, my mother, spent some time there. Um, so there was an inpatient medical health hospital. And I don't like asylums. Now, of course, there's all those horror stories of asylums drilling people into heads, giving everyone lobotomies, mistreatment of everyone. But sort of that idea of going to some place and staying there until you feel better and where you can be observed and treated day to day. Like, I imagine it a resort rather than locked in a padded room.
Yeah, there's places where it's more resort-ish.
Yeah.
Yeah.
Do you think that should make a comeback, or does that sort of exist? Do you know if that exists?
I mean, there is treatment centers that do help
Okay.
people with mental health concerns. Back in back in Mississippi, they called it the fifth floor of the hospital. The fifth floor was the psychiatric wing, and so when you hear someone going to the fifth floor, that's what you automatically think. And it was bad. Like, they had a psychiatrist called the Thorazine Queen because she would like pump everybody with Thorazine. I mean, it was really bad. I hope she's not practicing now, but anyway, it was so bad. Yeah, it's really it's not good when that's the title, right?
Mm.
Um, yeah, so
So,
yeah,
maybe a message from this conversation just now is if you're listening and you know someone who's maybe depressed, you might need to be the one to step up and help them. Or
yes, that's the thing.
addiction, depression.
They needed support. It's kind of like somebody going through grief. Hey, they're not going to. People will say, "Hey, if you need anything, tell me." A person in grief is not going to reach out like that.
No,
Very rarely will they, right?
no.
And the same thing with depression, or addiction. But yeah, with depression, a person needs that help because, as you mentioned earlier, the isolation or I'm pulling away from friends, that's part of what's happening with depression. And it's not that they don't want to talk about feelings. Like neurobiologically, people with depression have a really strong inability to get there in their brain because of what's being deactivated, whether that's the prefrontal cortex or the, let's see, uh, there's a few other ones, but I mean, even the amygdala, and it's just looking at all these different ways to activate certain brain areas and trying to bring down other brain areas. But I think the insula with depression is important because that's the ability to feel into myself.
Hmm.
And with depression, that can often be deactivated or minimized. So, and part of activating the insula is going out and talking with somebody, and it's hard to do that when I'm deactivated in that brain region.
And moving the body and confidence in moving the body. Now, oh my
Yes.
goodness, I'm trying to desperately go back to a seminar about the part of the brain for a sense of wellness. Was that substantia nigra?
Yeah, that sounds right. Yes,
Um,
attention eager. Yes.
is partly responsible for a sense of wellness and is actually nerve endings that feed into it from the neck position sensors.
Mm, yeah, interesting. So,
Someone who has chronic a neck injury or chronic neck tightness tends to one of the symptoms is a sense of disease. Like they
mm,
don't quite feel right. They feel like their life is off kilter. They don't feel their emotions are right. They don't feel well
yeah.
and uh yeah, and actually a lot of I now ask people when I suspect that they have a chronic neck problem. It's like, how do you feel?
Yeah. Yeah, totally. Like, yeah, what's going on for you emotionally there?
Yeah.
Uh,
And
you get,
and sometimes you have to treat both physically and feeling good. I mentioned it's feeling good about the body, all that visualization with the muscles, doing mobilization
yeah.
of the muscles. Learn. So there's such a fear of moving the neck muscles. They often have to relearn to activate muscle by muscle. And there's about 70 neck muscles.
70 neck muscles. So, do they have to look at specific ones for the neck muscles or like all 70? Or what is it like?
Well, it's a lot of the exercises are about trying to really slow down the neck motions. So it's so a lot of the exercises are to feel the segments. So I'll start near the top and I try to feel top moving, try to move it down a centimeter. See if you can feel a slightly different bone moving, something different stretching. So you're trying to just feel different segments as you're pushing firmly in. So sometimes I would be doing the force to make sure it's sort of at different levels. But you can sort of do it yourself where you're slowly going down centimeter at a time, trying to feel different things stretch and feel different things. And then
Mm,
once you've loosened things up, often these people's brains are so terrified of the neck because their brain has forgotten how to control it. They do functional MRIs. Part of the brain that controls the neck shrunk entirely. Like it's like 10,
wow.
20% what it should be. Because it's a massive
Wow.
area because we have more nerve endings per gram of muscle in our neck for control than for our fingertips. And it's by a factor of, I think, 700%. And you'd imagine, oh, our fingertips are so dexterous. Well, the control for our neck needs to be 7 times that. And our neck is a rope standing on end. And all our balance organs are in our head, and our head only knows where the rest of our body is through knowing where all the neck segments are.
Wow. Okay. It's amazing then what the neck provides us with information, eh?
So I will do
Yeah.
one of the control exercises with you because it's a little bit fascinating.
Okay.
And I have the patient try to move their nose, going across in a straight diagonal. So
Okay.
basically, they're moving their head and their neck, and they're
Okay.
trying to do it painfully slowly.
Okay.
And we're trying to, and someone who has chronic neck problems, it'll look like a stair step, or it'll be a curve, or it'll just be super, super shaky. So,
Oh,
audience, if
okay.
you're listening, hopefully you're not driving. We can give it a try. So you start at one corner, and it's
Okay.
about this pace. And I'll watch you. See how you sort of stopped there?
Yeah.
It's sort of hard to get going again. So now you're moving. You can move a little bit faster.
Okay. Yeah, I did stop. It's interesting, like micro stops.
Yeah, so there's little micro stops. So you just have little micro stops. Oh, there's another little micro stop.
Interesting. Yeah. Yeah.
So that becomes the practice is to get rid of the micro stops.
Mm,
And once all the micro stops are gone, normally the neck is much better.
that's amazing. That's really awesome to know. I mean, yeah, that's yeah. Mind blown, Dr. Remoto. Mind blown. Um,
So, depression, pain. Oh, facilities. One thing I wanted to mention because we talked about sort of you also almost need to bring someone. I want to tie this into another health problem, which is high blood pressure,
mm,
because there's a chiropractor who opened an inpatient blood pressure clinic, and he was telling me he often has friends or even coworkers bring in people and basically commit them and sign them in, and they're angry to be there.
yeah. Yeah.
A lot of people want sort of quick fixes. So they take the statin, the blood pressure lowering medication. They take reduced sugar, or sorry, not reduced sugar, reduced salt. A lot of people
Okay.
know that okay, high blood pressure, you need to avoid salt. Going on a salt-free diet or reduced salt reduces blood pressure by 3 points. And a lot of these people are 180 when it should be 120. They need their points reduced by like 60, and they think that and even their doctor's like, okay, go off sugar or go off salt. Going off salt, that's going to move it down 3 points. Three, and they need 60.
So it's so overblown. It's so overemphasized with salt. What else would they need to do to help themselves?
So his facility is sort of an emergency facility. Some people who are basically going to die because their blood pressure is so high,
Mm, okay.
and it's a diet intervention.
Okay.
The research suggests that the first 10 pounds you lose, if you're overweight, reduces your blood pressure by 10 points.
Okay.
So the
All
first
right.
thing to do is lose weight. And so his clinic is actually a fasting clinic. They
Mm,
don't necessarily do this is an emergency intervention. So they fast, I think, 5 days at a time or 6 days at a time under doctor supervision.
okay.
And this isn't, they're not in padded rooms or anything. They're brainwashed every day. Every day they take cooking classes. Um, I think maybe only cooking classes on the days they're allowed to eat. And they take biology classes and exercise classes, basically health classes. So they walk out of there, well, A, with lower blood pressure, but also being a little bit health experts.
That's good. That's awesome. They're basically a wellness coach at that point.
Yeah, yeah. Self wellness coach.
Yeah.
One thing I want to talk about is we're getting near the end, but I want your opinion on drugs. Now, I know you mentioned, I know you can't prescribe. I can't prescribe either unless I move to New Mexico. But you can't prescribe drugs, but we can still have an opinion and we still can comment on drugs and can educate patients on drugs. And they can have a conversation with their doctor. Sometimes doctors, frankly, they don't have the time, and sometimes they don't know. Oh, I hear this is what everyone's prescribing. That's what I'll prescribe. I saw a commercial about that, particularly in the States. Yeah, that's what the salesman told me to prescribe people. That's why I prescribe now. That's the hot
Hmm.
drug this year.
Yeah.
So patient education, I'm a big advocate. So what's your opinion on mental health drugs, particularly, let's pick on depression?
A patient, a client needs to do their research on the side effects. They need to know how long that drug has been around, and just because it's been around for a while does not mean it's necessarily there's validity and reliability with that drug. So I would say, yes, I need to look at what are the side effects, what are the clinical trials showing for even a new drug that's going on with side effects. Just asking even the doctor what has other patients experienced on this drug. I mean, they can keep confidentiality. They can say what are the side effects they've seen. So I think that's important. So I think just looking at really getting that informed consent is huge when it comes to depression. I mean, there's so many SSRIs and different ways to go about that. I know somebody personally that's been on an SSRI for over 10 years, and for her to try to come off of that is going to be like so difficult. So, like, I would ask myself, is this going to be a supplemental tool for a certain amount of time? And, how long, to what frequency of dosage? Can I ask my doctor about that? Like, what's the duration? Because most people, if you talk with them, they probably do not want to be on the drug for the rest of their life.
Mm-hmm.
Yeah. So just specifically talking about SSRIs or just drugs for depression and antidepressants, I would say that.
So I'll jump in. If you are going to do your own research, then you can look up sites like drugs.com is a fairly good one with some very basic information of interactions, side effects. Pretty much has every drug there. So that's a good one to start for your own self-information. Looking at research, you can Google some systematic review or meta-analysis with drug name or drug class. And then if you want to compare it with something else, Google with that as well. So
Excellent.
counseling or CBT, SSRI, systematic review. And you might
Yeah.
find papers comparing maybe the combination or one versus other. Systematic review, SSRI versus placebo.
Awesome. Yeah, I think that's really good to know.
And I'm going to summarize that information for the audience, although there's more than just SSRIs. And the research, actually, frankly, there could be more research. There could always be more research. It's a little bit, so I don't really think it's settled on how well SSRIs work in combination with counseling, with exercise. There are some studies, at least, that say the combination is best. Although often those combination ones don't involve a placebo, which is frustrating. But there are other studies that say exercise works just as well as SSRIs. But it's hard to exercise when you're depressed. Counseling on its own works as well as SSRIs. There are also meta-analyses that SSRIs work as well as placebo, but they can't prescribe placebo. You can't go to your doctor and ask for a placebo. But
Yeah, give me that
placebos work well and do work fairly well, and it makes sense because thinking changes your brain chemistry.
Yeah. Yeah, totally. Yeah.
So it makes sense that thinking something was going to help would help.
Yes. Yes. A self-fulfilling prophecy, like CBT, so yeah.
um,
A few other reasons. Sorry, go ahead.
well, I was going to say one of the theories about why SSRIs don't work as well is because our body is just so great at maintaining homeostasis, and that the SSRIs are so chemically habit forming. They estimate it takes just a couple weeks because serotonin reuptake inhibitors, that means the serotonin gets released, and instead of the body sort of cleaning up that serotonin, the body's inhibited, so that serotonin just floats around. So then what happens is the body's like, well, there's way too much serotonin. I didn't want that much serotonin because I'm depressed. I didn't want that much floating around. So it produces less, or it reduces the receptors on the other side. It can actually pull in receptors and have less receptors. And it only takes a week or so for the body to do that, which is why when you come off, now the body has to readjust all over it again.
Yes. Yes. It's like coming off of some type of mood-altering substance. It's, like cocaine would do something similar. So it's just, Yeah, some other resources, medscape.com is really good, just
If you
for,
if you have access to PubMed or something, but I know you can't
yeah,
get access to all of the. Although sometimes just the abstract is enough to know what the results were. So
yeah,
PubMed is good, Medscape is good.
there's a good app called EPO Crates, so EPO Crates, and you can see like drug interactions, stuff like that. Cochrane.org, I think.
Oh, that's
So see,
fantastic for because I think Cochrane only
yeah,
does meta-analysis.
yeah, so that's good to see the meta-analysis of all the different studies, being well put together.
Oh yeah, maybe for the audience,
Yeah.
we'll describe. There's different types of reviews. A narrative review, that's also a good Google term or search term. A narrative review is someone going through and writing just like a blog post summarizing the research. A
Yes.
systematic review is someone who, or a research group that goes through, they find every research paper and they summarize all the results. And
Yes.
then a meta-analysis, they actually try to take the results and they try to combine the results into one conclusion, if it's possible.
I saw one for exercise that was a meta-analysis, 17 different benefits of exercise. Wow. You know, yeah, yeah.
So this was great. Thank you so much for coming. Do you have any closing statements today?
No, I learned a lot from you today, Brandon. I always learn something when I get to talk with you. And so just thank you for having me on the Trilogy of podcast. Yeah, it's been a pleasure.
The pleasure's all mine, and thank you, audience, for joining us too. Um, Everyone, be well, get help if you need it, help someone else if they need it, and I wish you guys all the best. Cheers. Okay.